Assalamu alaikum. Our today's topic is the cranial nerve, uh, third cranial nerve, which is the oculomotor nerve. So we'll discuss the different components of the oculomotor nerve, the nuclei of the oculomotor nerve, its course within the cranial cavity, and its branches, and then its clinical significance. The oculomotor nerve is the third cranial nerve. It provides the motor and the parasympathetic innervation to the structures within the bony orbit. Now, the oculomotor nerve has the general somatic efferent component and the autonomic component. The general somatic efferent component innervates the majority of the extraocular muscles within the orbit and including all the recti, the inferior oblique, and the levator palpebrae superioris. The autonomic component has the parasympathetic supply to the sphincter pupillae muscle and the ciliary muscles of the eye. The sympathetic component has the no direct function, but the sympathetic fibers they run with the oculomotor nerve to innervate the superior tarsal muscle, which helps to raise the eyelid. There are two main nuclei of the oculomotor nerve, which are located in the midbrain of the brainstem. This is a section of the midbrain at the level of the superior colliculus. They are the superior colliculi, the cerebral aqueduct, and these are the crura and the interpeduncular fossa, the crus cerebri. So the oculomotor nerve has the main motor nucleus of the oculomotor nerve, which lies ventral to the cerebral aqueduct, and through this main motor nucleus, the oculomotor nerve emerges, and these fibers they run anteriorly or the ventrally between these crura into the interpeduncular fossa. Close to this main motor nucleus of the oculomotor nerve is the parasympathetic nucleus of the oculomotor nerve, which is called the Edinger-Westphal nucleus. From this Edinger-Westphal nucleus, the parasympathetic fibers they emerges and they run along with this main motor nuclear fibers or the somatic efferent fibers, the general somatic efferent fibers, and they also pass through this between these crura along with this main motor fibers. So the oculomotor nerve emerges from this main motor nucleus ventral to the cerebral aqueduct anteriorly through the brainstem and passing inferiorly to the posterior cerebral artery and superiorly to the superior cerebral artery. After emerging from the brainstem, from the midbrain, it enters into the lateral wall of the cavernous sinus. And in the lateral wall of the cavernous sinus, we have discussed the structures which are present in the lateral wall of the cavernous sinus again and again. And it is very important, and you should also again revise the structures and the relations in the lateral wall of the cavernous sinus. So as you know that in the cavernous sinus, the internal carotid artery is piercing in the cavernous sinus and over the along with this internal carotid artery, there is a sympathetic plexus around the internal carotid artery. So this oculomotor nerve within this lateral wall of the cavernous sinus, it receives the sympathetic fibers from the internal carotid artery. Now, these sympathetic fibers, they does not mingle with this main motor nuclear fibers or the general somatic efferent fibers of the oculomotor nerve, but they just travel along with this within its sheath. Then this oculomotor nerve, it leaves the cranial cavity through the superior orbital fissure. Now at this point, when it enters into the superior orbital fissure to enter into the orbit, it divides into two branches, that is the superior branch and the inferior branch. Now this blue one is showing you the parasympathetic fibers which are coming from the Edinger-Westphal nucleus. Now these parasympathetic fibers, they are also running along with this main motor fibers and they also pass through this lateral wall of the cavernous sinus, and they enter into the superior orbital fissure. Now, at the superior orbital fissure, they run along with the inferior branch of the oculomotor nerve or the main motor fibers. So it runs along with the inferior branch, and then in the inferior, then they supply the parasympathetic supply. So here, this is the superior orbital fissure. Now these fibers, they now entering into the orbit. So at this point, this is the superior orbital fissure. In this point, the oculomotor nerve divides into the superior branch and the inferior branch. Now the superior branch will supply within the orbit the superior rectus muscle, the levator palpebrae superioris muscle. And as we have said that their sympathetic fibers, they are also running along with the oculomotor nerve within its sheath. Now they will take the course of the superior branch, and the sympathetic fibers, they will supply the superior tarsal muscle to elevate the eyelid. After the levator palpebrae superioris has elevated it, they keep it elevated, the superior tarsal muscles. So they are supplied by the sympathetic fibers which are running along with the oculomotor nerve. Now this inferior branch of the main motor fibers or the oculomotor nerve, it supplies the three muscles within the orbit, that is the inferior oblique, the medial rectus, and the inferior rectus. Now these green fibers, they are the parasympathetic fibers showing you the running along with the oculomotor nerve and then into the superior orbital fissure, and they take the course of the inferior branch of the main motor fibers. So they run along with the inferior branch of the main motor fibers, and then they relay to the preganglionic fibers to the ciliary ganglion, which is located close to the optic nerve in the orbit. Now, these preganglionic fibers, they are related to this ciliary ganglion of the parasympathetic fibers, and then these postganglionic fibers, they are relayed to the sphincter pupillae and the ciliary muscles through the short ciliary nerves. So this is the basically the parasympathetic supply through the short ciliary nerves to the sphincter pupillae and to the ciliary muscles. Now this is the section showing you the arrangement of the extraocular muscles in the orbit. Now you can see here, this is the levator palpebrae superioris. This is going the superior oblique passing through the trochlea or the pulley, and this purple one is the superior rectus muscle. The green one is the lateral rectus muscle. It is cut to show the medial rectus muscle, and this blue one is the inferior rectus muscle. So this is all of the arrangement of these extraocular muscles for the movement of the eyeball. The motor supply or the general somatic efferent fibers of the extraocular muscles, they supply the muscles for the movement of the eyeball and the upper eyelid. The superior branch, which is supplying the superior rectus, it elevates the eyeball. The levator palpebrae superioris, it raises the upper eyelid. Additionally, the sympathetic fibers, which we have discussed, they travel with the superior branch of the oculomotor nerve. They innervate the superior tarsal muscle, which acts to keep the eyelid elevated after the levator palpebrae superioris has raised it. Now, the inferior branch, which is supplying the inferior rectus, it depresses the eyeball. The medial rectus adducts the eyeball, and the inferior oblique elevates, abducts, and laterally rotates the eyeball. The parasympathetic fibers, as we have discussed, they are running with the inferior branch of the main motor fibers, and they are supplying the parasympathetic supply to the sphincter pupillae muscle through the short ciliary nerves and the postganglionic fibers of the ciliary ganglion, which constricts the pupil, reducing the amount of light entering the eye. And the ciliary muscles, they contract and causes the lens to become the more spherical. That is, it means it is adapted for the short vision or the near vision. So the preganglionic parasympathetic fibers, they travel in the inferior branch of the oculomotor nerve, and within the orbit they branch off and synapse in the ciliary ganglion. Now, this is the injury of the oculomotor nerve or the oculomotor nerve palsy, showing you the drooping of the upper eyelid. So, this drooping of the upper eyelid is due to the paralysis of the levator palpebrae superioris muscle and the unopposed action of the orbicularis oculi. And this drooping of the upper eyelid is called the ptosis. So other functions of the oculomotor nerve will be lost. If the parasympathetic supply is lost, it will lead to the dilated pupil, and there will be the loss of the accommodation for the near vision. Then, if the action of the recti muscle is lost, so there will be the downward and the outward movement of the eyeball, and the eyeball will be in the position of the downward and outward movement. So this is the oculomotor nerve palsy, and there are various tests to test this palsy, but uh, you should remember just the applied anatomy or this clinical significance of the oculomotor nerve. So thank you, and now you will have your third substage, which is all about the eye, bony orbit, and all the structure of the eyeball and the extraocular muscles. So, and all the cranial nerves, that is the third cranial nerve, second, and the first optic nerve. So we'll discuss what will be the pattern of this substage. So I will let you know tomorrow. So thank you.